Good afternoon. I am delighted to introduce our final speaker. And I think I have saved the best for last. I think he's going to be a great person to wrap up our week-long series. Dr. Darrell Hudson is an associate professor at the Brown School at Washington University in St. Louis. His research focuses on racial and ethnic disparities and the role of the social determinants of health, particularly how social economic position and social context affect health and health disparities. He also co-directs the collaboration on race, inequality, and social mobility in America within the Brown School Center for Social Development. I am delighted to have Dr. Hudson with us here today. He is an amazing scholar, but also one of my really good friends who made my time in St. Louis bearable. So I appreciate it. I'm going to turn it over to you, Dr. Hudson.
All right, well, thank you so much. I really appreciate it. And thank you all for organizing this. Is really wonderful. And I'm happy to be here with you all and all the people who are joining us on this Friday afternoon. And just so delighted to be among that outstanding group of scholars. And I certainly am. I can't say I'm the best, but I'll try to do my best. I'm bad in cleanup, so there's a lot of pressure that I feel to to live up to the lofty introduction that Dr. Goodman has given to me. So if people can see my slides now, I'll proceed and straight away into the content for today, which is really thinking about privileging equity, even though we're in the midst of a very, at least in modern times, unprecedented pandemic. And so this is a pandemic that obviously is disproportionately affected people of color in the United States, particularly Black Americans and Latino Americans. And so I'll spend a great deal of time talking about why that is. And for many of us who've been studying these issues for a lot of years now, this wasn't necessarily surprising. And unfortunately, a lot of the underlying factors that we see are still there and they'll remain to be there, even if and when we do have a vaccine for coronavirus and COVID-19. These things will still be there, and hopefully we'll be able to, by privileging equity, do a better job. I always like to begin with the end at the front. So this talk should be unsatisfying to you. It should be something that just scratches the surface. I will argue that it would take a lot longer, even more than a semester, to go through all these complex factors to explain why these inequities are in existence, and especially as it relates to COVID-19. So that being said, if you have questions or you'd like me to comment on something that I'm not able to get to today, please feel free to email me there. There's my email there, d.hudson@worcester.edu. Here's the agenda for today. Thinking about the end at the beginning. So I'll start with some resources that go beyond what I'll be talking about today, some things that are directly related to the content for today, and some things that a lot of people ask me, what can I be doing right now, especially at the end of a talk, action items. So I'll give you some of those things right up front. We'll also talk about the impact of COVID-19 in the United States and talk about the disproportionate impact on particular communities of color. I'll outline some key concepts that are related to health equity. So defining some key things like fundamental causes, for instance, to explain why these inequities occur. And then we'll talk a little bit about where to go from here. So thinking about resources, Derek Griffith was on yesterday, and so I'm not sure if he promoted these texts that he helped to co-edit. So one is the textbook, Racism, Science and Tools for the Public Health Professional. Dr. Keon Gilbert was also a co-editor for this one here. And this is a relatively new textbook that just came out last year that's published by the American Public Health Association. There's also Men's Health Equity, which is important for obvious reasons, especially as it relates to what's happening right now, especially around Black men's health in 2020. Some media resources that are freely available. So especially people there in New York probably know that the New York Times Magazine had the 1619 issue that came out last year in print format. And so that's a really outstanding print edition that's really hard to get. I didn't get a chance to get a copy, but they also had a accompanying podcast. So this is a 6-part podcast that is really relevant to things that are happening in our country right now. There's even an episode that talks about healthcare and particularly healthcare policy and why healthcare policy looks the way it is in the United States. Another podcast that I really enjoy is America Dissected, which is organized by Abdul El Sayed, who is the former commissioner of health from my hometown, Detroit, Michigan. And so the second season of that focuses all about coronavirus. So he interviews people like Tony Fauci to talk about what's happening with coronavirus in terms of testing and getting results back, and also some of the kind of social and economic spillover from the pandemic. Some other media resources that are available. One is the Serial podcast. So this is a pretty entertaining podcast in my humble opinion. But the third season talks about criminal justice. And it really dovetails the intersection between sentencing disparities, particularly through plea deals. So if you ever wonder how people come to plead for things that they may have not even done to get lesser time than they would if they went to a jury trial, this is set in Cuyahoga County, which is where the city of Cleveland is seated. And so I think this is a really good examination thinking about health and all policies, to think about beyond just health and healthcare, but to also think about criminal justice as well. And lastly, in terms of media resources, I would promote Unnatural Causes. So at this point, this seems like an oldie but goodie. This was a documentary series that was produced in 2008. And so this features some of the people that were on this call, particularly Kamara Jones, and as well as many other public health professionals who are doing this work, and really does a good job of explaining, especially to a broad audience, why these inequities are making us sick, and tries to privilege not just for people who are quote unquote vulnerable, but what could be our societal gain if everyone had access to their highest level of health. Some additional resources that are available on the web. One would be the Interdisciplinary Association for Population Health Sciences, available at iaphs.org. Also the Society for Epidemiologic Research. And so these are two organizations that are thinking about population health, that are thinking about the disproportionate impact of COVID on communities of color, and are doing, to me, a really outstanding job, not just in terms of tracking the surveillance of coronavirus, but also thinking about what can we do, again, privileging equity as we pivot away from this pandemic. Other things that people can do right now, if you're at home, you're wondering what can you be doing from the comfort and safety of your home. One organization is called fairfight.com, which is an organization that was started by Stacey Abrams, who was a gubernatorial candidate in the state of Georgia, who, let's just say, lost due to some voting irregularities and shenanigans. And so in the face of her defeat by Brian Kemp in Georgia, she started fairfight.com in order to make sure that people have access to not only access to the right to vote, but also make sure that they're able to get their votes counted. And so this has become a national movement. Another organization is called votesaveamerica.com. And so if you're in a quote unquote politically red state, like I am right now, sitting in Missouri, you can go to votesaveamerica.com and adopt a state. So these would be swing states like my home state of Michigan, Arizona, North Carolina, Wisconsin, places like that. Or if you're thinking about for not just for the presidential election, but also for local and state elections that are really critical in terms of setting policies that can help to address some of the inequities that I'll be talking about. Those are some of the resources that I will recommend and things that you can do right now from the comfort of home. So just pivoting out of that sort of introduction, thinking about the impact of COVID-19, we know that almost 17 million people have been affected globally. Around just about 9.8 million people have recovered. And we have about 665,000 deaths globally. And we know there's growth in middle income countries such as Brazil. In the United States, we have 4.46 million cases. Around 2.17 million people have recovered, with about 155,000 deaths. These numbers keep changing. And even right before I got on today, these numbers keep going up. And just to put that in context, so thinking about prominent wars that the United States has been involved in, you can think about the death toll from some of these wars, from the Revolutionary War, World War I, Korean War, Vietnam, the War on Terror. And we can see, compared to some of these really prominent wars that we all learn about if you're growing up in the United States in US history class, that this pandemic is really, really impactful, especially people there in New York. You think about 9/11, almost 3,000 people were killed in 9/11, but just this year already, we have over 32,000 COVID-19 deaths in the state of New York and almost 23,000 deaths in New York City alone. Again, kind of dwarfing the numbers of people that have been killed in Afghanistan and Iraq that are active wars that are still ongoing. And relating to health equity, the patterning of coronavirus transmission, as well as the severity of COVID-19 cases, has not been equitable. We know that vulnerable populations, such as older adults, frontline healthcare workers, so these are workers not just including the providers, so physicians and surgeons, but also people who are in the janitorial staff, as well as other support care team members, are disproportionately impacted by COVID-19. We know that homeless people, undocumented immigrants, as well as incarcerated people have been particularly vulnerable to coronavirus transmission. And overall, we know that Black and Brown communities have been disproportionately impacted. In fact, nearly 30,000 Black people in the United States have died of COVID-19. That amounts to 1 in 1,350 Black Americans having died just since the beginning of this year. That's a death rate that's 3.7 times the rate of whites. For Latinos, there's over 22,000 Latino deaths from COVID-19. That amounts to 1 in 2,700 Latino Americans, and a death rate that's 2.5 times that of white Americans. I also want to note that COVID-19 has a tremendous impact, not just on in terms of death and obviously for suffering from people who've had this condition and recovered. Not only that, but also the impact on our economy, people's job losses and things like that. And all those things relate to mental health. And so I won't spend much time talking about the impact of COVID-19 on mental health, but I think it is important to take a note. We know that whenever there's a major trauma or stressor, especially at a population level like a pandemic, we know there's going to be increases in mental health conditions, including depression, anxiety, substance use disorder, as well as incidents of domestic violence and child abuse. We have to acknowledge that people are experiencing tremendous loss and are not able to comfort one another in the ways that we typically do. So we can't hug people and comfort them and have a going away that we're typically accustomed to. You know that physical distancing is effective in limiting the transmission of coronavirus, but it's certainly associated with loneliness. We know that people are stressed due to job loss. So many people have been furloughed or lost their jobs altogether. We also know there's family conflict. So when people live in close quarters, especially, and they have their children at home and kids are no longer going to school, and just the stress of trying to homeschool your child, in addition to perhaps working from home and other people being at home that are typically outside of the house, that's going to increase family conflict, which increases stress, which could make people more vulnerable to mental health conditions. So just as a note there, I would say that we at bare minimum need to improve our surveillance systems and to reinforce our mental health services to deal with what's happening right now. So those are some of the impacts of COVID-19 right now, the pandemic. Just to go through some key concepts to kind of frame things. So I like to start things off with a definition of health. And according to the World Health Organization, health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. But what are the building blocks of health? So how do you achieve and maintain health? A lot of it goes to individual choices. So especially around diet. So whether you decide to line up in the morning and have a stack of pancakes or a bowl of oatmeal, or whether you prefer fresh fruits and vegetables to, say, fried foods. But going beyond individual choices, and even those individual choices are often deeply impacted by the neighborhoods in which we're embedded. So this is a picture from the city of Detroit, where I'm from. And something that's unique about Detroit is that Detroit is absolutely enormous. You can fit the city of New York, Boston, and San Francisco inside of Detroit with room to spare. It's a city that used to have over 2 million people and now has about 700,000 people. So a lot of that depopulation lends to a lot of our blocks, our city blocks looking like this, where you can see there's a lot of dilapidated housing, really broken up streets, and even it's an extreme strain on city services in terms of trash pickup and lighting. So if you drove through the city of Detroit at night, there's for miles and miles, a lot of times there's just pitch black darkness, which certainly doesn't indicate that it's a safe place. And not only is it not a safe place, but you probably wouldn't feel comfortable going out and getting physical activity with these types of structures there. Right up the road in Flint, Michigan. So I did some work in Flint before I returned back to Ann Arbor, where I went to graduate school. And Flint has always been, at least as long as I've been alive, been deeply impacted by social and economic issues long before the Flint water crisis. This is a picture I took about 10 years before the Flint water crisis. And it's interesting there, you probably can't see this tagline here, but there was a tagline there that talked about Flint being clean. And that was kind of a tongue in cheek that it wasn't. And so you can turn the page to the West Coast, thinking about Richmond, California. So Richmond is an interesting place because it overlooks the San Francisco Bay. You can see outstanding views of the Golden Gate Bridge, very beautiful. But Richmond is home to a lot of oil refineries. And so lo and behold, if you look at kind of environmental assessment maps, that area is home to a lot of people who have asthma. And if you have childhood asthma, you know that you'll be more likely to have days off of school, and that impacts your academic progress and achievement. So all these things, again, these are not areas that people are, say, opting into. These are places that you're born and you're raised, and you don't have very much agency over what resources are embedded in those neighborhoods. So what, again, you're socialized to believe is delicious, whether it's a fast food restaurant, you're maybe not even socialized to believe is delicious, but could also be what you can afford. So it could be fast food restaurants, also what resources or what adverts are in that area, what is marketed to you that should be salubrious to health. So you can juxtapose those experiences, say, of Richmond, California, or Detroit, or Flint, versus a neighborhood that looks like this, which is a picture of Pacific Heights in San Francisco, which is one of the richest neighborhoods in the United States. And you can think about what resources are available in Pacific Heights. And it'll probably be much more appealing and better resources, places that you can, again, get fresh fruits and vegetables to maintain a healthy diet. There'll also be places that you'll be more likely to get physical activity, and you can get that physical activity while having to worry about your safety. In terms of diet, again, these building blocks, again, context is very important in terms of what is socialized, how we're socialized to think about what's delicious, what we can afford. Even for me growing up, and not to take a shot at this canned veggie company, but a lot of the veggies that I ate when I was growing up, they were what I call disintegration grade vegetables, where all the nutrients have been absolutely zapped out of the canned vegetables, because that's how people were accustomed to preparing them. So another building block, again, physical activity. And so you can think about it being damned if you do, damned if you don't. So in the tragic case of Ahmaud Arbery down in Brunswick, Georgia, just going out to get physical activity, this ended up costing this young man's life, unfortunately. So, and people like sociologist Rashawn Ray have documented for a number of years now that even Black men who are upwardly mobile, so people who have college degrees and have high occupational prestige positions, they feel unsafe going through certain neighborhoods. Even Dr. Goodman has documented this here in St. Louis. Certain big city parks, people feel like they're under surveillance in these parks and these spaces. So even though it's a place that should be health promotive and places that should protect health, that might not be in terms of the feelings that people have. They might not feel safe going to those areas. Similarly, if you live in an area that doesn't have well-maintained parks, you might not feel safe going there either. So again, the impact of the built environment on health behavior. So let's take a little bit of a deeper look at context. And you can think about context as these multi-level factors that all these things press upon individual level health as well as population health. So you can think about going from these broader social and economic policies, how those things influence institutions, which in turn influence our neighborhoods and our communities, down to our social relationships as well as our individual risk factors. You can also think about how these factors occur over the life course, and again, are influenced by our physical and social environment. So multi-level factors pressing again on individual and population level health. So context is really important. In a nutshell, you can think about when I ask the question, what is health? You can say, what exactly is the context of health? Context, again, is important because it shapes our social norms. So what's available, what's affordable, and what's acceptable in your particular network? How are opportunities to engage in certain behaviors reinforced? Are they truncated or are they completely absent? So again, the example of safe spaces to recreate. And how does context produce stress? So again, if you live in a neighborhood that's poor, that is not as safe, there's high levels of crime, if you have a small child, you're probably not going to ask that child to go out and get physical activity, which again, that shapes social norms over the life course. So people might be privileging the immediate safety of their child over their long-term health, say their heart health, or making sure that they can prevent obesity and overweight. And then you can also think about how resources are available, what resources are available to cope with chronic stress. So if people are living with a great deal of stress and stress that is not going anywhere, not being able to regularly pay one's bills on time, not being able to navigate a community without thinking about how unsafe it is. Those are chronic stressors. And so what resources are available to cope with those stressors? As I showed in those pictures before, a lot of times, especially fast food restaurants and alcohol companies, et cetera, are very capable and do a really good job of marketing what their products are and how salubrious those products are, and especially helping to cope with stress. Policies and practices make a big difference in how our neighborhoods look today in the United States. One suite of policies that were absolutely transformational in the United States were New Deal era policies. And so if you were born and raised in the United States, you had US history, you probably were exposed to this when you were in 10th or 11th grade, but it's not, the story is not told from an equity perspective. So some of the policies that were there are not necessarily given a nuance. So to highlight some of the nuances there, one video that I would recommend, which I guess would be an additional media resource, will be Segregation by Design. This is a 17-minute video that is narrated by Richard Rothstein, who is the author of The Color of Law. And so Segregation by Design, the 17-minute video, sort of is like a crash course in why the United States looks the way it does in regards to race and ethnicity in our neighborhoods. And it captures some of the nuances that are oftentimes untold when we look at a standard US history class. So I think that's a really good, neat video. And whenever I share it with students or a general audience, people are always surprised at some of the things that are there. As I mentioned before, The Color of Law is there. Another book that is interesting to take a look at is When Affirmative Action Was White by Ira Nelson. And both of these texts talk about these New Deal era policies. Again, these are policies that for many Americans, you're probably exposed to these in 10th or 11th grade. So you may have heard of or known people who were, or maybe yourself, benefit from the GI Bill. Now, the unfortunate thing about the GI Bill when it was initially implemented is that there was not equitable access to the GI Bill, such that returning service people were not given equal access to attend four-year colleges and universities, particularly Black and brown people. If you think about where Black and brown people lived at the time, especially Black Americans, they lived in the Southeast United States. So states like South Carolina, Georgia, Mississippi, and Alabama. And at that time, the state flagship schools, especially places like the University of Mississippi, University of Alabama, were not admitting Black students. You weren't allowed to go there. So you weren't allowed to use your GI Bill at the state flagship university. So you were steered towards either technical schools, two-year community colleges, or historically Black colleges and universities. And I'll be the first one to tell you that as a graduate of a historically Black college, there's absolutely nothing wrong with going to a HBCU. However, you do get differential access to networks. And so we know that as we look for jobs and we try to establish our careers, who you know is absolutely critical in determining your trajectory. And so if you have differential access, again, to the GI Bill, then those things are felt not just for that individual, but across generations. Another New Deal era policy was the Social Security Act establishment. And so this is essentially our older age insurance. It's one of the only older age insurances that we have in the United States. So as people age out of the workforce, they had some sort of security that would sustain them into their older age. And so we know there was two employment categories that were conspicuously absent or excluded from the Social Security Act. One was domestic workers and the other was laborers. So people who are quote unquote laborers included people like farm hands or sharecroppers, as well as domestic workers. So domestic workers, people who are childcare or maids and things like that. And if you think about, especially back when these policies were initially implemented and developed, these were disproportionately Black women in domestic worker roles and Black men, as well as Black women who are working as sharecroppers or working in the fields in general. The New Deal era policies were also really formative in establishing what neighborhoods look like. So some examples of that would be the establishment of the Federal Housing Authority, as well as the Homeowners Loan Corporation. And the combination of these policies made it possible for suburban single-family mortgages to be less than rent in urban cores. So essentially, it incentivized people to move out of urban city cores into the newly established suburbs. And you can hear the rhetoric right now. Just the other day in 2020, people are starting to talk about, we want to keep certain people out of the suburbs. So this has a deep, long history here. Another practice that people, that really was influential in determining what neighborhoods look like was redlining. So this was simply banks outlining in red. So here you can see the legend, red being labeled hazardous, and you can see the city map of Chicago here. And so certain neighborhoods were outlined in red, and those banks would not loan people money to develop property or to establish that home nest egg in certain communities. So fast forward to modern contemporary times, we can still see the cleavages of redlining today. And sometimes it's just simple built-in environment. So as Dr. Goodman mentioned, being in St. Louis, we see these really elaborate city structures, and they're beautiful edifices, but they're certainly meant to keep certain people out. Even just a few weeks ago, you may have noticed on the news that there was a couple in one of these gated communities in St. Louis that had their guns out, and they were brandishing their weapons against protesters who were marching down that street. And this is about a mile away from where I'm sitting right now. I know a number of colleagues who live on that particular street. And this is Portland Place, so this is a close-up look at what that street looks like. And there's these private streets that a lot of times there's a police officer that's seated there to keep people out. Again, you see the gates that are closed. And so again, that forms as a kind of structure, a literal structural barrier to keep certain people out and to make sure things are segregated. So what does this mean in terms of social economic resources? Most Americans derive the majority of their wealth from their home value. And so we see tremendous differences across race, ethnicity in terms of wealth. And these differences have not sort of dissipated over time. They've only grown over time. And I would say these numbers are probably a little bit inaccurate, one, not accounting for the current pandemic and downturn that we're experiencing right now. And also for many Black and brown people, they take out a tremendous amount of debt to pursue education. So for many people, for many Black and brown people, they might actually have negative assets. They might have debt in the hundreds of thousands of dollars when they were financing their education. And again, as it relates to segregation, as long as we have high levels of segregation in the United States, we'll always have these immense differences in wealth. So turning the page to fundamental causes, which is another term that people think about, and you can define and describe fundamental causes as access to resources that help people avoid diseases through multiple mechanisms. So these could include mechanisms like neighborhoods and contexts, could also be resources like wealth. These affect multiple disease outcomes through multiple mechanisms. So again, they're fundamental. So they affect not just one outcome, but multiple outcomes and through many different pathways. And these fundamental causes continue to affect different outcomes, even when risk profile changes. So this means that even as diseases come and go, the distribution of different diseases are similar over time. So you'll see that people who are marginalized, people who have the least amount of resources, always seem to be the most disproportionately impacted by whatever disease there might be of the day. You can also see that even if you intervene at, say, an intervening mechanism or eradicate some diseases like polio and other vaccine preventable diseases, there's always going to be an association between fundamental causes and diseases that either reemerge or new diseases that and conditions that come up. So examining how coronavirus initially spread. If you think about just in January, our first cases in the United States, these were people who were typically well off, so they were well-to-do. There were people who had traveled to other places, say China or Italy and other places. And then you can look at who's most, again, that slide that showed you who's most disproportionately suffering right now, or certainly is not affluent people who are having the privilege to travel. Another fundamental cause, I would say, is racism. And so thinking about how racism has impacted the policies and practices that I talked about before. So redlining, there's also restrictive covenants, which again, the city where I'm in, St. Louis, is famous for its restrictive covenants and barring people from selling their homes to people of color. There's also a number of other policies and practices that I'm not going to have time to talk about today, but urban renewal and how highway construction has eliminated certain communities. There's block busting as a technique that is mentioned in that video that I mentioned, segregation by design. There's also steering. So people have demonstrated through audit studies that real estate agents will disproportionately steer Black and brown people to certain neighborhoods. And there's also differential access to mortgage products. And so this is on the right hand of the screen here, this book, Racism Without Racists. A lot of people think about racism strictly as an interpersonal factor. So thinking about people treating someone unfairly because of their race. But you have to think about it as beyond that, as a broader sort of institutional or structural level factor as well. And so even if racism, as Eduardo Manila Silva says, is this colorblind factor, there's many different ways that, again, New Deal air policies, practices like redlining are still manifesting themselves today that don't have anything to do with interpersonal racism. Another way to think about as we sort of pivot in a moment to understanding the COVID-19 inequities is upstream and downstream determinants of health. So in this particular graphic, you see here this factory that is conceivably dumping out some pollution into a river that this fellow is drinking. And obviously there might be some deleterious health impacts from consuming that water. So one might say, well, if you go upstream and to address this problem, you will say, let's get rid of this factory, or let's regulate it, or figure out a way to stop this factory from making people sick. However, we know that people work at that factory. And so it becomes sort of a wicked problem to ask people to get rid of this factory because people are depending on that job. So their jobs in that factory may be privileged over the health of an individual. And we can kind of see that right now with the upstream and downstream determinants of the coronavirus. You see here, this sign here, the cure is deadlier than COVID, or fear is the real virus and the virus and not the economy. these are real live examples of these upstream and downstream determinants. Again, downstream is easier to address, but thinking about what you have to do upstream to make it happen. I also think there's an interesting juxtaposition. Just about 6 years ago here in the city of St. Louis, Ferguson, Missouri is a suburb of St. Louis, and how protests are differentially treated here. And so depending upon who's protesting, so if you see in state capital of Missouri and Columbia, people are congregating and protesting the sort of stay-at-home orders and mandates to wear masks and things like that. In my home state of Michigan, people marched on the state capitol with their rifles and all that, and we can see how people are treated differently according to what they're protesting for and who they are. So, highlighting that disparity, I thought I would spend a little time defining what health disparities are and what health equity is. And so, according to the National Institutes of Health, health disparities are differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. To kind of summarize what health disparities are, you could say that they're systematic, unfair differences in health across race and ethnic groups that are plausibly avoidable as they are fueled by policies and practices, not necessarily by genetics. So people often talk about a zip code, not a genetic code, being the key factors that drive health disparities. And oftentimes disparities in health place socially and economically disadvantaged groups at further disadvantage in regard to their health. So some population health indicators that we often use to kind of take the temperature of our population health and compare across race and ethnicity. One would be infant mortality, where we always see twice the rate of infant mortality among Blacks and whites. And what's unique about infant mortality is that it's not necessarily explained by socioeconomic position. In fact, we find that Black women who are highly educated, who have great amounts of education, who live in and work in environments that are not as hazardous or have high occupational prestige, they are just as likely or more likely than, say, poorer white women to have low birth weight, preterm birth, or infant mortality. Also more likely, especially with age, and people talk about this concept of weathering. So the accumulation of stress over the life course that could place people who, again, even if they're upwardly mobile, at risk in regard to their health because they've experienced a lifetime of disadvantage, not just this kind of snapshot of upward mobility that we often see in our data collection efforts. Another population health indicator that we often see is life expectancy at birth, and we know there's about a 6 to 7 year difference between Blacks and whites in regard to overall life expectancy. We also know that when we break this down by gender, so when we add in the gender component, we see that these differences are exacerbated even more. So those are some examples of health disparities. We define health disparities. So what is health equity? Health equity is this notion that everyone should be able to attain the highest level of health possible and should not be disadvantaged because of their social position or other socially determined circumstances. So striving towards health equity involves creating opportunities and removing barriers to achieving the fullest health potential for all people. So many of you have probably seen graphics like this that sort of show that equality doesn't mean equity. And so some people will need more help to get to their highest level of health. The other graphic that you often see is people looking over a fence at a baseball game. So as rudimentary as these graphics may be, I think they do a good job of explaining this concept of health equity. And again, showing that you have to do some things, whether it's from a societal or community level, to help people to get to their most highest level of health. So let's review some of the key concepts that we've covered so far. So we defined health, we outlined some key protective factors, particularly around diet and exercise, that kind of underpin some of the disparities that we see. However, we've underscored the importance of context and note that context is absolutely critical. There's a strong influence on the key protective factors that we can at the individual level do to protect our health. We know that context is not random or due to character flaws. So people who are, say, in poverty are not people who are just choosing to get into poverty or choosing to live in an unsafe, poor neighborhood, but really this confluence of strong policies and practices that have accumulated over a long period of time and that are really intergenerational. We also know that there's upstream and downstream determinants of health, and upstream determinants are much more difficult and is sometimes politically sticky to address. There's also fundamental causes. So we know these involve resources that make it possible for people to avoid risk against certain diseases, able to maintain a higher level of health. And then we've also defined health equity and juxtaposing health equity versus health disparities. So health disparities being simply the differences that we recognize in health, but health equity being this idea that people can get to the highest level of health that they can achieve. So let's use some of these concepts to explain what we're seeing in the current pandemic, and especially around racial ethnic inequities around COVID-19. So some of the explanatory factors there would be employment in essential services. Again, as I mentioned before, people employed in essential services, not just including healthcare providers, but also people who work at fast food restaurants, people who are in janitorial services, other care teams. We know there's substantially higher level of Black and Latino people who are employed, especially healthcare workers who are employed in essential services. We also know that Black and brown people are more likely to live in intergenerational households. And this is certainly true for myself. I was raised by my grandmother. So if I was working at a fast food restaurant, which I did way back in the day, if I worked at McDonald's right now, I could potentially go home. Or if I was a food delivery person, or if I worked in janitorial services in a hospital, I can come home to my grandmother and I can pass on coronavirus to her. And that's where some scholars believe that we're seeing some of the disproportionate impact on people of color, because there's more people in a household. From an equity perspective, we have to pay attention to that. We have to make sure that we craft our communication strategies and messages, knowing that it's not just people who are visiting their aunts and uncles or their grandmothers, but some people actually reside in the same household. There's also a lack of access to health care and testing. So especially at the front end of the pandemic, people who are feeling symptoms will recommend to go and call their primary care provider and to get tested. But if you're not connected to a primary care provider, that's essentially an empty directive. So I like this quote by Martin Luther King Jr., who says, "It's a cruel jest to say to a bootless man they lift himself up by his own bootstraps. It's even worse to tell a man to lift himself up by his own bootstraps when someone is standing on the boot." So again, demonstrating that some people have not had adequate or equitable chance to prevent the coronavirus transmission and are disproportionately impacted by it. We also know that there's a wide range of health comorbidities that make people more likely to experience the deaths and the severity of cases related to COVID-19. So 76% of Black Americans are overweight or obese. Over 60% of Black Americans age 50 or older have hypertension, and almost a quarter of Black Americans have diabetes. So in relation to the slides that I shared earlier, to context, we know that we shouldn't blame the victim here, because we know that people live in neighborhoods that simply do not have the building blocks, especially around maintaining a healthy diet or getting regular physical activity. People can't do those things in environments where those things simply do not exist. So what we're seeing in terms of the medical comorbidities are really these kind of cleavages of context, which again are related to these broader social and economic determinants of health, including at structural level policies and practices that were not equitable in the first place. Another key factor is stress. Stress gets under the skin and is highly corrosive. We know that stress impacts our immune system functioning, which I'll talk about in just a moment. Stress is associated with many different deleterious health outcomes, everything from cardiovascular disease to diabetes and overweight and obesity. We know that stress accumulates over the life course and could accelerate the aging process. And as I mentioned before, this is true even among people who are upwardly mobile, because oftentimes people who are upwardly mobile and are people of color lack wealth. So people are trying and efforting an incredible amount just to get to the same level from an income or educational perspective of oftentimes their white peers. So this comes at a traditional additional stress. So in addition to the stress and strain of just studying hard and working to attain upward mobility, people are oftentimes trying to navigate these environments in which there could just be out and out racism, there could be differential treatment. People are trying to navigate environments they didn't grow up in and kind of get exposed to. And so all these stressors taken together could lead to compromised immune system functioning. Oftentimes people who live in community settings, particularly college students who live in dormitories, think about finals time. So every semester I noticed that in teaching students, they start to get sick. So I start to get a lot of emails telling me that people are going to be missing class, or people are going to be going to the doctor's office and they might be late, et cetera. A lot of times that's because people are staying up all night. They're not getting enough rest. They're really stressed out because of the papers and the exams that they're trying to prepare for. And so their immune system is weakened. And if you stretched out, if you kind of extrapolate that brief time, that finals time, into people living an entire life where they're, again, every day you don't know what might bring a new stressor, not having enough money to make ends meet, all those things could affect immune system functioning over the long period of time and make people more likely to be exposed to, and to not just be exposed to, but to be affected by coronavirus. Also explaining these things would be socio-political ideology. Oftentimes we don't pay a lot of attention within public health about some of these socio-political ideologies. One is the American Creed. So there's this emphasis on individual efforts. So this assumes that outcomes are different because effort and choices are different. But we know that some people, again, depending upon where they're born, what neighborhoods they're born into, what families they're born into, it's not just their effort and their choices, but it's also what access they have and whether these environments are equitable. Oftentimes we have an ahistorical perspective. So people often push back at some of the notions that I've shared with today, saying things like, well, I never owned a slave, or I worked really hard and other people could too, but not paying attention to, again, this kind of untold or forgotten history that we see with New Deal era policies. So not just going back to slavery, but going to things that happened within the 20th century that were really fundamental and have done a tremendous job of structuring what our neighborhoods look like and what health looks like. And there's also this concept of deservingness and the policies that we implement and develop as a result of who's deserving. So as I mentioned before, New Deal era policies were developed and implemented to help pull the country out of the Great Depression. And again, New Deal era policies created the middle class as we know it in the United States, as well as the suburbs. But we know there was differential access to New Deal era policies, as well as redlining practices that kind of undermine people's efforts to develop in certain communities. So lastly, where do we go from here? So next steps, one thing that we should acknowledge is that we've already failed communities long before COVID-19 showed up. And if we're not careful, we'll continue to fail those communities. So I will hope that people will use this pandemic, as well as some of the other social movements that are occurring right now, that will go beyond just a t-shirt, that will go beyond just slogans from companies, and really serve as a wake-up call to privilege equity. We should also interpret the inequitable impact of COVID-19 as a societal failure, not as an individual level failure. So not to blame individuals, but to make sure that we think about and consider the contextual and socio-political policy and practice factors that have made a big impact on who's most likely to be exposed to coronavirus and to develop COVID-19. And I would say we also have to do a better job of making sure that everyone has access to their highest level of health, so privileging health equity. So what does that mean in the short term? So I think a simple thing to do would be to have a coherent communication strategy. This might include tailored messaging, as I mentioned before, for people who live in intergenerational households, people who are employed in essential services. So making sure that we have a communication strategy and a coordinated strategy from the federal government on down to local governments to make sure that our efforts are in lockstep and there's not this sort of 1 minute once a person is saying one thing and then another minute someone else is, so better coordination across different sectors. To improve the access to testing and processing speed, so even when people are tested now, oftentimes people are not learning their results in an efficient manner, so we have to invest in infrastructure there. And also thinking about addressing basic social and economic needs. So just this week, the short of employment insurance expired for many people. So if we're going to ask people to stay home to reduce the spread and transmission of coronavirus, we have to make sure that we are providing the basics in terms of social and economic needs that people need to be able to observe that. For public health people on the call, if you're really interested in learning about some of the kind of fundamental nature of a lot of the things that I've talked about, a paper, an academic paper that you can take a look at is called Sick Individuals and Sick Populations by Jeffrey Rose. And this talks about cases versus causes. So cases being individual level factors and causes being population. And then thinking about high risk strategies versus population strategies. So population strategies, according to Jeffrey Rose, are radical, have large potential for population, are behavioral appropriate. So asking people to do things that are in line with their normal lifestyle, not asking people to do things that are misaligned with their day-to-day life. But we know that people, no matter what the benefit for population, these strategies are always threatened by the prevention paradox. And so this is the idea that if you do such a good job of preventing something, then people will start to ask, why are we investing in this? And we saw this with vaccines, and that's something that's important to consider as vaccines are developed for COVID-19. Will people actually take it? If we see many of the kind of childhood vaccine preventable diseases that we've done a good job of suppressing or eliminating, like mumps, rubella, et cetera, people start to ask, well, should we continue to do this? Is this related to other factors? So again, that's an example of the prevention paradox. So just paying attention to the population benefit, but also knowing that people will start to ask, why are you investing so heavily? Another strategy is curb cut effects. So focusing on people who are most vulnerable. So the example there that I like from Angela Glover Blackwell, who's the president, former president and CEO of Policy Link, is this idea that if you're confined to a wheelchair and you were rolling down the street and you got to the end of a street and there was no ramp, what would you do? Well, you can chance it and take a plunge and you can fall and do some damage. You can go around that curb and add some time and make yourself late or something like that. But if you put a curb cut, so if you make an indentation, simple indentation in the sidewalk, a person in a wheelchair can easily navigate that curb. Not only that person in a wheelchair who might be considered most vulnerable, but people who are on bicycles, people who are pulling their luggage, who are fully able-bodied, but they still benefit from that particular curb cut. Examples prominently, one example where everyone benefits will be New Deal era policies. So if we can think about population level strategies, again, such as the New Deal era policies, that could be a curb cut. So lastly, just thinking about some of the ways that we can extend beyond COVID-19, think about overall racial inequities in health and what we can do about it. So one is alignment of resources. We have to think about who's at the table and go beyond just systematic, symbolic representation or palliative policies, but to really ask people, what do they need to be the healthiest they can be? We have to think about science policy. So if racism and poverty are some of the fundamental causes that drive the health outcomes that we see, if you look at the National Institute of Health, I think there's 27 of them. They all have to do with diseases and body parts, but none of them have to do explicitly with, again, poverty or racism or any of these other social and economic factors that really are fundamental to what's happening on the ground in terms of health. this year thinking about who's being counted, so people participating in the census so that the right amount of resources are allocated and right amount of representation is allocated. And also thinking about, again, moving the needle. So there's a number of policies, curb cut policies that can be used as population strategies. Also politics, so making sure this year, as I mentioned, the front end, making sure that people are exercising their right to vote and making sure that we can do a better job of finding people who will represent the best for the country, especially those who are disproportionately impacted by this particular pandemic. So thank you all for your attention. I really appreciate it. And looking forward to some of the Q&A.
Thank you so much, Dr. Hudson, for an amazing presentation. You really brought us home. If we were in church, the collection plate would be going around at this moment. I'm going to ask one question, which I think someone is looking for clarity, so I'm going to reword it a little bit. Can you give some examples of upstream factors versus downstream factors?
Yeah, sure. So an upstream factor would be, like I mentioned before, it would be something like broad and big, like how do we eliminate poverty? How do we eliminate racism? How do we address these big factors that influence these downstream factors? Downstream factors might be something that people feel like they have a little bit more control over. Like as a public health professional, we love to build community gardens. We like to establish these sort of food markets that you can associate with the community garden. It feels good. People are kind of empowered to do that. But in the grand scheme of things, those don't change the upstream factors much at all. So again, the upstream factors being things that are a little bit more difficult to change, politically more expensive, need more buy-in, downstream solutions being a little bit easier, but are really kind of located at the like intervening level.
So I think they just are going to ask this same question at every faculty. So I'm going to give it to you because we've asked almost everyone else. What do you think is the best way to roll out the coronavirus vaccine? Should certain groups be prioritized over others? Which groups and why?
From an equity perspective, I would think that it would be important to pay attention to that. So assuming that, especially since we don't have the infrastructure built up to create millions of vaccines and get them out immediately. So knowing there's going to be sort of a phased rollout of vaccinations, I would think that from an equity perspective, we will highlight those who are most vulnerable. That would include people who are employed in essential services, especially healthcare workers. It will also, to me, in my ideal world, from an equity lens, would include people who we know are disproportionately suffering. So thinking about the beginning of the talk, seeing who's being disproportionately impacted. Do I think that will happen? I doubt it, unfortunately. But that's what I would say would be take into account who's most disproportionately impacted, who's most vulnerable, and allocating the initial sort of phases accordingly.
And a follow-up to that question from another participant, what are some factors that you believe are necessary to prevent inequity in vaccine accessibility, but also mistrust in vaccine science?
Yeah, I think that's a really good question. It's something that I've thought about a lot. I'm glad that question came up. It's just this mistrust in science in general. So even among my own family and my network, people are like, I'm not taking a vaccine because this is a conspiracy. So oftentimes to me, I always tell my family members that the truth a lot of times is not as appealing as the kind of fantasy or the realities that people are trying to paint on social media platforms, for instance. So there's a tremendous amount of misinformation that is out there about what's occurring. I know people here in Missouri who think that this is not real. And I can tell people, being from Detroit, knowing people who have had COVID, people who've recovered, people who passed away, this is absolutely real. And so I think from a communication standpoint in establishing more trust, we have to do some tailoring of communication. We also have to think about where people were at in their history of sort of being victims of, say, experimentation and things like that. I think we also have to use peers. So using peers who can help to, so it wouldn't help be, to me, it wouldn't be as helpful for someone like me or a Tony Fauci or a Jerome Adams, a certain general, to stand on TV and say, you should take the vaccine. I think we have to go at a local, more grassroots level to think about who are some of the key factors here, who are some of the key players, how can we educate those folks so they can kind of transmit that message to their broader network. So that's why I would say, I know that's probably not satisfactory, but those are just some of the thoughts I have off the top of my head.
So I'll ask one of the questions from one of the participants. How should mental health disparities be addressed in relation to COVID-19? You mentioned this a little bit earlier in your talk around the mental health issues.
Yeah, sure. So behavioral health in general is not adequately funded. It's very difficult for a lot of people, even if they do have healthcare coverage, to access behavioral health care. So that's something we have to think about from a general perspective, is that some people are not going to be able to access mental health care. So what can we do in the face of that? So one thing, and I think that, necessity is the mother of innovation, right? So we've seen more and more kind of virtual supports that are being developed around the country. So whether that's telemedicine or peer supports that are happening through Zoom, there's ways that we can to address some of those things. Some of it will improve over time as things kind of quote unquote get back to normal. But I think that from a public health science perspective, we also have to temper people's expectations and letting them know, like, normal is not going to be a snap of the fingers. It's going to take a long period of time to get back to normal, because you can imagine that, as the previous question came in, some people won't take the vaccine. We need a certain percentage, 75% or something like that, of people to take the vaccine to get to herd immunity. So if those people are not, if there's 50% of the population who says they're going to opt out, then we're not going to have the freedom and range of movement that you would expect when things are quote unquote normal. So all that being related to behavioral health, again, thinking about people who are disproportionately impacted by the losses, not just in terms of loss of loved ones, but also job losses, furloughs, the loss of school, et cetera. Those are things that people are under a tremendous amount of stress. And so the better we can calibrate the limited resources that we have to address that among those vulnerable populations, the better.
Thank you.
Can you talk about what you think it would take to shift policy and funding priorities more towards upstream factors, since they're so important?
Yeah, sure. That's a really good question too. I think there's a number of different things. One is to make sure that there's more representation at the science level, so science policy level, making sure there's people who are trained like myself and Dr. Goodman, who are there helping to structure what policies look like. So what are the funding mechanisms dictating what type of work is going to get funded? We also have to do a better job, like I said before, of not just having the symbolic representation, but making sure that people who have the lived experience, who are experiencing the brunt of inequity, making sure those people's voices are heard. So that requires something different that we haven't quite done. So right now you can do a public comment on a lot of the different policies that are being considered, but most people don't know anything about that. And a lot of people are dealing with their day-to-day life in such a manner they don't have the bandwidth to participate in something like that. So we have to make sure that we're somehow gathering that information and acting on it and making sure that stuff is brought to the fore so that it's considered. Also, I think there's no substitute for experience. And so having more people who have experience in equity, who can explain what's happening on the day-to-day basis on the ground with them, the better. And I think people who have never lived that life, they make a lot of assumptions, and making sure that we can get those people to the table will be, to me, pivotal and can help make a transition.
I promise you I didn't write this question, that it is from a participant. What is the role of participatory action research in addressing health equities and building trust in communities?
Yeah, sure. That's a great question. I think that you could probably answer that question better than I could. Um, to me, it's got to be more than, like I said, just kind of lip service, symbolic representation. I think to do authentic, um, truly impactful community engaged work, you have to look at community partners as equals. And with that, they have the same amount of decision making power as the whatever the organization might be that you're a part of. And so, and that's really difficult. And sometimes that's really painful, even for people who have the best intentions. And so I think that, you know, adhering to a lot of the principles that are out there, so whether it's the CDC or other practices, Dr. Goodman has a great book on community engaged research and partnerships. And so I think that the more we can again privilege people, treat them as true partners and not just kind of lip service, like we're going to do this for funding purposes, but the more we can bring those people to the fore, the better. And again, I think a large part of it too is making sure we find representatives of communities that are not just the usual suspects. So every, at least academic organization I've ever been part of has always had these kind of, I don't know what the right word is without sounding completely pejorative, but they always have the same people that they're working with. And so I've always wondered, where are the people who have kind of conflicting views? Where are the people who might be offering a more nuanced position, who might not be fully bought into the project that I or my colleagues who are bringing this to the table, they might be skeptical. And so I think we have to do a better job of making sure that we find those people, highlight their stories, highlight the fact that they are valid, and doing a better job of lifting up those perspectives.
Given the overrepresentation of Black and brown bodies in the criminal justice system, what role do you think incarceration has in producing racial and ethnic disparities? And how does the criminal justice system fit into actions for mitigating COVID disparities?
Sure, I'm glad that question came up too. That was one of the reasons why I highlighted the Serial podcast and thinking about sentencing disparities and mass incarceration. So I think that plays a tremendous role in overall health inequities. You can think about health in all policies. So anything that has to do with social and economic factors is going to be important as it relates to health. So not just in terms of like the kind of breakdown of the family from a sociological perspective. So not having a parent in the home, which is a tremendous loss. Not having a parent in the home also relates to a loss of income, a loss to, in terms of contribution to society and to that person's community. It has a tremendous impact in terms of the resources that people have around them as well. So, and in very few situations that I've ever seen anecdotally or scholarship-wise, are people simply just saying, you know what, I'm just going to go out and sell drugs today because that's what I want to do for a living. A lot of times it's because that's the only thing that people know how to do. It's the only show in town. So there's all sorts of people who are more eloquent than me who have described how if you don't have a good athleticism, if you don't have the jump shot or the throwing arm, et cetera, that is requisite to kind of rise up out of certain communities, that it's just not going to happen for you. And I think if that's the reality for a lot of people, that's a societal failure. And that does manifest in mass incarceration. There's also, in terms of policy, the sentencing disparities are influenced by these kind of mandatory minimums. And actually, at a practice level, they're influenced as well by people taking plea bargains. So the more we can do in terms of, and there's legal public health kind of partnerships that have developed over time as well. Those are some of the things that we can do to address that. And I can go on and on, especially here in the St. Louis area. The Department of Justice issued that report on civil rights here in the aftermath of Ferguson, and it showed that Black and brown people, particularly Black people, are disproportionately impacted by sort of traffic stops. And so there's this sort of feeding of the coffers that happens in a lot of municipalities around St. Louis. So people are pulled over for quote unquote poverty taxes, like a broken tail light, expired tags, et cetera. And those fines are used, and also the jail time that occurs from people having those violations, those things are feeding the sort of revenue for these very small municipalities. So a very important question. I know, again, that's not satisfactory. I can go on and on and on about that one, but yeah, the criminal justice and sentencing disparities, et cetera, those things are inextricably linked to the racial ethnic health inequities that we see.
So for our last question, we're going to ask, what is one thing that you think participants can do to help address some of these issues that you've brought up?
Yeah, sure. So I think a big thing is, one thing is to see people as people and not problems. So if you have that orientation in life, no matter what you are, if you're a public health professional, if you're a healthcare professional, no matter what you're doing, if you see people as people and not as problems, that makes a big step. Another thing that I think people can do is look at some of the resources that I shared at the beginning. So looking at Vote Save America, looking at fairfight.com, and trying to help people to vote and to exercise their right to vote. I won't tell people who to vote for and what to vote for, but being educated about what the politics are in your local community, as well as at the national level, is really critical. Everything to me boils down to politics, essentially. And so the more we can do to be well educated, the more that we can get people to represent the interests of people who really need the change, and finding people who represent those interests, the better. And so I would say, making sure that people, especially this November, but if there's local elections before then, to make sure that you're getting out to exercise your right to vote, and encouraging everyone and your network to do so as well.
I have to thank Dr. Hudson, and you guys, if you want to put all the thank yous in the Q&A now, you can flood the Q&A with your thank yous. I have to thank you immensely. I think you were the perfect person to close us off of a week-long series where we really learned a lot and had great discussions. Again, I want to thank all the participants who attended. I hope you guys found this informative. And I also want to thank all of our previous speakers and our GPH staff who made all of this possible. I'll turn it over to Dr. Ompad so she can say her thanks as well.
Well, I tend to be emotional, but I think that this has been a really, really great week. It's been very informative. I've learned a lot, and clearly I have a whole bunch of reading to do, because each of our speakers have really provided some amazing suggestions and resources for us to think more about the issues that we're facing during this COVID pandemic, and even globally, kind of beyond COVID, but all the health disparities that exist in this world. The one thing I'd like to say, we did mainly, sorry, I'm like, there's a bug in here. We did mainly focus on the US. And in the US, most of the disparities that we tend to focus on are racial and SES disparities. But the social determinants of health and what's most relevant is going to vary by context. So even though we focused on mostly racial and ethnic disparities, and then to some extent poverty, that doesn't mean that the things that we've been talking about this week cannot be relevant to other contexts, right? So the social determinant might be different, but the issues that people face are very similar. If they are not the people with the privilege and the power in the communities in which you live. So I hope, number one, I hope this inspires you to think about public health as a career. So come to the dark side, because you can help shed light on the world. And I hope that it makes you think about how you can be a part of the solution to dealing with all these disparities that people face, and to make the world more equitable. So thank you guys for being such wonderful participants. Thank you, Dr. Hudson, for being such an amazing wrapper-upper. And of course, thank you to Dr. Goodman for being my partner in crime.
Thanks again, everyone. Hope you enjoyed it.